Hello everybody, welcome to the Lifeproof core series, day 1 of 4. Welcome in. Again, this is a audio recording of the lectures that we're going to be going over throughout the course. So if you miss a day or if you need to touch back up on some concepts, feel free to refer back to these videos. I hope they serve you well. So a little bit about me, if you do not know me already. My name is Miles Gorder. I own a company called Milestones Movement that was founded upon the basis of promoting movement quality over movement quantity. So I've worked in the fitness industry for many years, 5+ years, and I've noticed a few things as I've gone along. And for one, there's a whole lot of emphasis that's placed on the quantity of movement these days. You go into the gym, people want to know how much weight you can squat, how many repetitions you can do that weight, how fast your mile time is, getting into athletics, how high is your high jump, how hard can you throw a football or a baseball, how fast can you throw a baseball, all that kind of thing, which is all talking about quantity of specific movements. And really what's lost there is that there's this underlying responsibility of the body to produce a quality movement, to move well before we move often. So furthermore, a lot of and especially in American society, we've become very sedentary. And we've got these weekend warrior types of people who sit all day at their desk jobs, and then they go and they try to, complete a very hard workout after work to combat the effects of sitting all day. And what happens when you sit all day is your body deconditions and it loses good brain-body connections. It loses neural conditioning. You lose neural conditioning and patterning of efficient, pain-free movement. And you develop compensatory patterns that then get exploited when you go and you do, forceful, heavy exercise, like going to your exercise class or like running a marathon on the weekend after you've been sitting all week, right? So Milestones Movement was just trying to, founded it upon that goal of changing the narrative of let's talk about movement quality before we talk about movement quantity. It's great to move often. It's great to move as much as you possibly can. But really where the problem lies is we've been so deconditioned, or a lot of us have been so deconditioned, either by sedentary lifestyles or past injuries or whatever the case might be, that if we go and if we're not moving well and we try to move often or try to move more with improper mechanics, that's where we run into issues and we get injured, and then we run through this whole cycle again of resting, rehabbing, and then not quite getting at the root cause and getting injured again. Anyway, long story short, that is kind of the background of what Milestones Movement is. Lifeproof Course Series is a course put on by Milestones Movement, put on by me, and from there, let's go ahead and get started. So moving on to the next slide, in the class we're going to ask you guys this, but I'm wondering, why are you guys here? Just get a feel for the audience, and a lot of you will bring up the fact that you're in pain. There's a lot of marketing around back pain specifically for this core series class. Some of you will be in here for performance purposes. You're trying to become more efficient mover. You're trying to reduce your risk of injury maybe, or you're trying to improve upon some performance goal, whether that's improving your squat, or improving your mile time, or improving your performance in a sport. Whatever that might be, core function is absolutely vital to those goals. So next slide. So we're going to start going over some concepts of the kind of backbones of this course and of my philosophy and of Milestones Movement philosophy. And they're really going to be deeply ingrained in everything we do moving forward. And the first of which is especially relevant for those of you who are in pain, who are going through that process of trying to figure out what's wrong, seeing doctors, seeing specialists, who all put in their 2 cents about what the problem is. And for our purposes here, I want you to go ahead and just drop that diagnosis if you have been given one. If you haven't, don't worry about it. But the point here is, sure, diagnoses are good for a lot of reasons, okay, and they can kind of pool together symptoms that apply to, in general, specific conditions, where a doctor can then categorize you and say that, okay, you have this disorder or disease or whatever the predicament is, and then you can seek treatment based off of that diagnosis. Here's my issue, is that the minute that you're going to seek help, and you're going, so let's say you're in back pain, and it's been lasting for months and months, just not going away, it's getting worse. Every time you get home from work, you got to lay down on the ground for 30 minutes, and you're like, something's got to give here, I got to get some help. So you go to the doctor, and the doctor goes, okay, let's maybe take some MRI imaging, something like that. Okay, you got some bulge discs. Okay, you've got degenerative disc disease. Right? He slaps that label on you. The minute you start that process, you're already expecting the doctor to be able to fix you. And especially in this society, we've developed this need for a quick fix, or this magic bullet approach of, oh, I've got degenerative disc disease. Okay, there's got to be a surgery for that, or a pill for that, or something that I can just easily do to get out of that predicament. And that is the entirely wrong approach and mindset to have if you want to really get at the root cause. If we want to get at the root cause, let's use degenerative disc disease for example, that is almost always caused by poor mechanics for years and years and years. And then eventually you have one incident that maybe slips a disc or herniates a disc or gives you some kind of acute injury at the disc. Or you've got this chronic issue of a disc bulge occurring, and maybe that's pressing on nerve that's coming out of the spine, and that's what is causing your symptoms of the back pain. Again, these are just examples. But if that was all brought on by improper mechanics for years and years and years, why should we then expect a very simple fix or a very quick fix? That is usually not the case. And all the quick fixes that are out there, whether you have a biochemical intervention of a pain pill, not fixing the root cause, right? It's going to help your symptoms, but it's not going to fix the root cause. The surgery, okay, maybe it gets at the root cause of the bulge disc, for example, but if nobody fixes your mechanics, if you just get that surgery and then you go right back out and start doing the same thing that you've been doing for years and years, you're not going to fix that root cause. The root cause was the improper mechanics that led to that injury. So we need to then, and not to mention, usually there's all sorts of side effects that go along with surgeries that ideally, if you can avoid, you should avoid. So, not to say don't listen to your doctor, do listen to your doctor, but do know that the quick fix is going to be the thing that they tend to go to, right? Physical therapy, much more along the lines of my thought process here, of let's address the mechanical issue, or the biomechanical issue that's causing that problem, and then go from there. But that's going to come from you. That's my whole point here, is this has got to come from you. It's going to take some time. It's going to take some effort. But this is something that you are going to fix on your own. I'm going to give you the guidelines, but you're going to do all the work. Okay, so let's start putting that responsibility back onto ourselves as we move forward here. So if we go to the next slide here, our next sort of concept, right, and we kind of started to touch on it in the last slide of, again, if we use the bulge discs as an example, pain science is really, really cool stuff coming out about pain science these days. And essentially what they're saying is that pain is truly, it's not a characteristic of tissue. Rather, it's an output or a symptom or perception, I like that word, of your brain that's perceiving danger and telling you that there is danger and that you should alter or do something differently because of that. So in this video here that you guys are going to watch in the class, Lorimer Mosley, who's kind of a leading mind in the pain science industry, uses an example where he is walking through the brush, probably in Africa or something like that, and he gets clipped by a twig, and that stimulus or input travels up to his brain. His brain perceives it, danger, no danger. He goes, let's put some meaning behind this. I've been here before. I've been clipped by a twig, and I was totally fine. I'm going to then shrug that brush off or that twig off and continue walking along my merry way. He then used the example of after that twig cut him, he then got bit by a snake, a very venomous snake, and almost lost his life. But the next time he was walking through brush and got clipped by a twig, he had a very intense pain reaction because his brain had put some meaning behind that stimulus and perceived danger and said, last time you were here, you almost died. So let's make sure that you do not do this again. I'm going to make sure you're in so much pain that you understand that. So the brain does some really, really awesome and interesting things. But that stimulus of the twig pricking the leg was the exact same or close to the exact same in both scenarios. So why did at one point in this person's life they react without pain, and in one point they react with pain? There's all sorts of cool things about MRI imaging as well these days. So if you take an MRI image of two people, and let's say they're the same age, to minimize variables, and one of those people has, again, we'll go on kind of on this disc trend that I'm working with here, has really severely bulged discs, maybe some herniation, something going on, right? It just doesn't look right. And the other person, maybe some degeneration, but overall not too bad. That person that doesn't look so bad could be the one that's in extreme pain, and the other person could have no pain symptoms at all. Which just goes to show that it truly is not a characteristic of tissue. It's not that the disc was bulged to a certain percentage or amount or whatever it might be, and that is the leading factor for that means a little causal effect of that is causing pain. It's not how this works, and that's why I want you to understand this concept of pain science. So when we're trying to reduce pain, and that's what a lot of you guys are here for, we want to change either the input, right? So if it's, again, on the bulge disc pressing on the nerve, if we can change the input and get the disc to not press on the nerve, that can then change the stimulus that's going to the brain. That's just going to change the output of pain or lack thereof at that point. Or we're going to change the perception of the brain. So we're going to make the brain feel more comfortable. We're going to alter the mechanics of the spine so that we, maybe we're taking pressure off the disc, but the brain then is becoming more comfortable with that stimulus. It's no longer in that sensitization process that can get worse and worse and worse as time goes on. So how are we going to do this? We're going to do this through altering our movement mechanics. That kind of brings me to the next slide there, movement. Movement is our means to an end here. This is our means of altering our brain's perception, of altering the stimulus that is causing the brain's perception. This is truly getting at the root cause, you guys. Almost any musculoskeletal disorder, aside from trauma, can be linked back, usually, to poor mechanics. And that's super powerful. So if we can change those mechanics back to a way that our body and brain are comfortable, then a lot of the times we can bring ourselves out of pain. So we're going to do a nice, cool little demonstration here, or a little experiment on how well you can sit and stand. So this study was done and basically looked at a whole bunch of people and correlated the ability of somebody to sit down and stand up without help from their hand or without losing balance or their knee pushing up off the ground to mortality rate. And they actually were able to correlate this, and it was pretty darn cool. So what you can do at home there, and if you weren't in class or you just want to do this again, is you're going to try to sit down to the ground and stand back up, and you start with 10 points, and you lose a point for every time that your hand, knee, forearm, or elbow touches the ground. You also lose a point for every time your hand, knee, forearm, or elbow pushes off yourself. So if you like push off your knee, for example, or if you push off the ground or something like that. And then you lose a half a point for every time you lose balance. So losing balance would mean that you have to, step out and alter your center of gravity so that you don't fall over, right? Or if you're going down to the ground and you fall back on your butt, you would lose a half a point. So why don't you try that and score yourself. So subtract your points from 10. And what they were able to find was that there was a correlation between musculoskeletal dysfunction, which kind of broadly categorizing what was potentially going wrong in that screen, to mortality rate. And what they found was that each increase in the sitting to rising test score was correlated with a 21% improvement in survival. So if you went from a 7 to an 8, let's say, you have a 21% more likely chance to survive. People scoring 8 or fewer points were twice as likely to die within the next 6 years. So pretty kind of cool stuff. You might say, oh, people that can't do this are old, right? Or if you don't score well, a lot of old people might not score well. Well, that's probably the case, yeah. But let's take a look at why the elder population is having trouble with the screen, okay? And that's because they're losing their ability, their musculoskeletal function of stability and mobility to be able to pattern these movements. So kind of cool. I always like to do that little demonstration. It's just a cool way to sort of show you how important movement is, and put a few metrics behind it. So let's say that you did not score so well on that sitting to rising test, and we were wondering why. Why am I not so good as, say, the person next to me at doing this? If we go over to the next slide here, you'll see this joint-by-joint approach. And this was coined by the FMS founder, one of them, Gray Cook, and Mike Boyle, I believe is his name, strength and conditioning guy, was a concept or theory on how the body works based on the joints. And basically what it says is that the body is a kinetic chain. Each joint is preceded and subseeded, whatever. The joint after the previous one and the joint before the previous one are all connected, okay, in a chain. And the function of each of those joints varies alternately. So if we start down here at, let's say, the big toe joint, the big toe joint likes to be very mobile, and then taking another step back. So if something was wrong with that sitting to rising test, one of two things was likely dysfunctional, and that's mobility or stability. We can kind of generally, umbrella movement into those two categories. Mobility and stability, I'd say stability motor control is a better general term for that section, but think there, brain-body connection. Are we able to engage the right muscles at the right times to stabilize a joint or to pattern a specific movement, to sequence those muscular contractions, to pattern an efficient, pain-free movement, right? Coordination, that's another term you might hear me say. Mobility is much simpler. It's, can the joint passively move through a range of motion? If I were to take your limb and move it in different positions, could it get there? If it can't, there's some type of joint or soft tissue restriction preventing it from getting there. And that's obviously going to affect the way you move. So this joint-by-joint approach says that each consecutive joint is either mobile or stable, and it switches at each joint. So the big toe, for example, likes to be very mobile. That's its primary function. The midfoot likes to be very stable. The ankle likes to be very mobile. The knee stable. The hip joint mobile. The pelvic lumbar region stable. Thoracic spine mobile, and so on. And usually when something goes wrong with movement, where we have this, some type of dysfunction, it usually occurs because the joints that like to be stable start becoming more mobile, or are required to become more mobile. And the joints that like to be more mobile start to become more stable. And that causes issues up and down the chain, as you can imagine. So that's kind of our next concept. And all of these concepts now are going to start to factor into the rest of the course. So what we're going to start with from here on out is talking about different common dysfunctional movements, outline why they might occur, and then go over certain correctives to improve upon those dysfunctions, to make them a little bit more functional, if you will, and in turn help decrease the stimulus or the perception of the brain and help decrease pain, increase efficiency if it's performance you're looking after. So the first one we're gonna check out is breathing, and breathing is the movement that you do the most. To be quite frank, you breathe all day, every day, and it truly is a movement. So you can, if we go here to the next slide, you can generally categorize breathing into two different movements, and that would be belly breathing versus chest breathing. A belly breath, as you can see there on the left, would be as you inhale, and both of these are using your diaphragm. It's just depending on the actions of how it's contracting and where the movement is occurring. So a belly breath, when the diaphragm contracts, pushes outward on the trunk and the belly in all directions, not just forward. Okay, and a chest breath pushes outward on the chest, so you'd see the chest rising versus the belly rising. Now, in general, we like to promote the belly breathing pattern because, for one, usually chest breathing is associated with higher stress jobs or lives, and people shallow up the breathing and start to inhale and expand the chest. Okay, that can tighten up muscles up around the chest and the upper back. The scalenes, for example, can get tight. The shoulders can round forward. We can develop kind of a kyphotic or hunched over posture just from breathing patterns alone. The other thing, so belly breathing can help to basically down-regulate the nervous system in a way, just via breathing. And then mechanics also of the spine, right? We talked about potentially the thoracic spine hunching over. The chest breath also facilitates an anterior pelvic tilt, or a big arch through the lower back. So if you take a deep breath in through your chest, you can try this right now, and let the chest rise, you will also feel how the lower back might want to arch. If we are lacking proper mechanics through breathing alone, this can change our spinal positioning and mechanics through the spine. That can be a poor stimulus, or the brain can perceive it as a dangerous thing and fire off pain receptors. So that alone, right, breathing alone is very, very, very important that we get down. So what you're going to do as a corrective here in class that we'll go over is you're going to practice belly breathing by doing something called crocodile breathing, where you're laying on your stomach, head in your hands, and you're going to use the ground as feedback. So you're going to take a deep inhale, you're going to push your stomach into the ground and let your lower back rise up off the ground, and try to limit any movement through the chest. You're also then going to flip over on your back, and you're going to practice motor control. You're basically going to get really good at going, okay, I can do a belly breath, and I can do a chest breath, and I can alternate back and forth and understand what's what. If you can do that, then you can for sure keep things, breathe, or keep the movement down into the trunk, abdomen, and a belly breath. So you'll lay on your back, you'll have a hand on your chest and a hand on your belly, and you're going to inhale into a chest breath. So you're going to let your chest rise and your belly fall. You're going to exhale. Then you're going to inhale into a belly breath. Let your belly rise and your chest fall. And you're going to go back and forth and get really good at alternating those. Okay. Then the last thing you're going to do is a self-resisted breathing exercise, where you are laying on your back. You're going to bring your feet up off the ground, your knees into your chest, and you're going to put just enough pressure onto your quads so that you get some core activation. and you're going to start breathing into your belly with the core being activated. So this now completely changes the game here. So a lot of people are very good at belly breathing passively, but the minute that we get some type of tension through the body, and especially through the trunk, it's much less intuitive to breathe into that tension and build pressure into the abdomen. So you're trying to build, and that's actually one of the reasons you're doing it, is you're trying to build intra-abdominal pressure by directing the breath into that contracted core, and in turn increasing stability. So just enough pressure to where you're challenged but successful. Okay, you'll hear that term a lot. You'll hear me say that all the time. It's very important with a corrective that you are challenging your system so that your brain has to learn something, so it's not too easy. But you've got to be successful, and successful in these terms is maintaining a belly breath. Okay, if you are not successful, you are basically telling your brain what success is and what it's not at this point. If you let yourself chest breathe, your brain will understand that as success, and it will continue to chest breathe. If you don't let yourself chest breathe and you force the belly breath, your brain will learn that's what you want it to do. Okay, so that's the end of day one. We will convene in a week, and the other videos will be up online, so feel free to move on to the next one. Thank you guys.